Hello everyone, welcome back to BioVision. There's an important discussion happening in geriatric medicine that many seniors and their families aren't fully aware of. While routine health screenings are crucial for staying proactive earlier in life, major organizations like the U.S. Preventive Services Task Force, USPSTF, the American College of Radiology, the American College of Cardiology, and the American Geriatric Societies Choosing Wisely campaign emphasize that after age 70, or especially after 75, the potential benefits of certain screenings can diminish significantly. At the same time, risks such as complications from procedures, unnecessary follow-ups, overtreatment, anxiety from false positives, and even radiation exposure may increase due to age-related factors like multiple comorbidities, reduced life expectancy, often under 10 years for many over 80, and physiological changes that make recovery harder. Current guidelines, including USPSTF updates through 2025 and Choosing Wisely recommendations, strongly advocate for shared decision-making. This means having an open conversation with your doctor about your individual health status, estimated life expectancy, using tools like the e-prognosis calculator, prior screening history, personal values, and preferences. Overtesting in older adults can lead to overdiagnosis, finding incidental things that might never cause problems in one's remaining lifespan, or overtreatment, where interventions carry more harm than good, potentially reducing quality of life without extending it meaningfully. Research from large cohort studies, such as those published in JAMA and the New England Journal of Medicine, shows that in adults over 75 with limited life expectancy, the absolute benefits of many screenings drop below 1 to 2% for preventing serious events, while harms can rise substantially. Today on BioVision, we're diving deep into 5 common screenings that experts often recommend reconsidering after age 70. We'll explore the underlying science, current guidelines, potential risks with real data, and safer, evidence-based alternatives, all backed by high-quality studies, meta-analyses, and official recommendations. Stick around, you might be surprised by number 1. Before we start, drop a comment below. Where are you watching from? How old are you? Have you or a loved one ever paused or stopped a routine screening based on doctor's advice? We're reading every comment and replying with personalized, evidence-based insights. Don't forget to like this video and subscribe to BioVision for more science-driven health content tailored to real-life decisions. Now, let's jump in. Number 5. Bone density, DEXA, scan for routine osteoporosis screening. The DEXA scan, or dual-energy X-ray absorptiometry, is a quick, low-radiation, non-invasive test that measures bone mineral density, BMD, at key sites like the hip and spine to assess risk for osteoporosis and fragility fractures. According to the USPSTF's final recommendation statement published in JAMA in January 2025, screening with DEXA is strongly recommended, grade B, for all women aged 65 and older, and for postmenopausal women under 65 at increased risk, using tools like FRAX. For men, the evidence remains insufficient, grade I, to recommend routine screening at any age without risk factors. Importantly, there's no strict upper age limit in the 2025 guidelines, but for adults over 75, especially those without prior fractures, symptoms, or high-risk features, decisions should be highly individualized based on life expectancy and overall health. Bone loss accelerates naturally with aging due to hormonal declines, e.g., estrogen in women, testosterone in men, reduced physical activity, and nutritional factors, much like gray hair or wrinkles. Mild osteopenia or even osteoporosis is extremely common in this age group, affecting over 50% of women over 80. But many cases don't progress to problematic fractures if life expectancy is limited. Treatment with bisphosphonates, e.g., alendronate or zoledronate, can increase BMD and reduce fracture risk in select patients. Meta-analyses show relative risk reductions of 30 to 50% for vertebral fractures and about 36% for hip fractures, but absolute benefits are smaller, often preventing just 1 to 3 fractures per 100 treated over 3 to 5 years in lower-risk older adults per FIT and Horizon trials. Side effects, though rare, under 1 to 2%, include gastrointestinal upset, esophageal irritation, atrial fibrillation risks, and very rarely jaw osteonecrosis or atypical femur fractures. For many asymptomatic seniors over 75, the real game changers are non-drug interventions. Multiple randomized trials and meta-analyses in journals like Osteoporosis International and the Cochrane Database show that weight-bearing exercises, e.g., walking with resistance bands, strength training, balance training, Tai Chi, or yoga 2 to 3 times/week, adequate vitamin D, 800-2000 IU/day from sunlight, supplements, or foods like fatty fish, and calcium-rich diets 1,200 milligrams per day from leafy greens, dairy, sardines, or fortified foods can reduce overall fracture risk by 20–40%, often comparable to or additive with medications, but without the side effect risks. Fall prevention is key. Home safety modifications, removing rugs, improving lighting, vision checks, and multifactorial programs reduce falls by 24%, per USPSTF fall prevention guidelines. If you're active, eating well, haven't had falls or fractures, and have a life expectancy under 10 years, discuss with your doctor whether repeat DEXA scans, typically every 2 years, or meds are truly needed. Studies suggest intervals of 4 to 10 years may be safe for stable patients. Number 4. Brain MRI for mild memory concerns or forgetfulness. As we age, it's completely normal to experience occasional forgetfulness, misplacing keys, forgetting names, or word-finding pauses. This is often due to normal age-related brain changes, like slower processing speed, not dementia. Guidelines from the American Academy of Neurology and ACR appropriateness criteria recommend against routine brain MRI for mild cognitive complaints without red flags like rapid decline over months, seizures, sudden personality changes, focal weakness, or headaches suggesting a mass. In older adults, MRIs frequently show age-related findings, slight brain atrophy, white matter hyperintensities from small vessel disease, or enlarged ventricles. These are common in over 80 to 90% of people past 70 per population studies in neurology and rarely indicate a treatable condition like a tumor or hydrocephalus. Unfortunately, spotting these incidentalomas can trigger significant anxiety, unnecessary additional tests like PET scans, lumbar punctures, or blood work for rare causes, or even inappropriate medications that cause side effects. Large reviews in neurology and JAMA show that only 3 to 8% of abnormalities in mild cases lead to actionable, reversible diagnoses. The emotional toll, fear of Alzheimer's, can worsen quality of life, sleep, and even cognition more than the memory issues themselves, per qualitative studies. A safer, evidence-based first step, simple office-based tools like the Mini Mental State Exam, MMSC, Montreal Cognitive Assessment, MoCA, or MiniCog. These are quick, free, validated with 80 to 90% sensitivity for detecting impairment, and guide whether further evaluation is needed. Lifestyle plays a massive role. Meta-analyses of RCTs, e.g., Finger Trial and Lancet Neurology, show regular aerobic exercise 150 minutes per week, Mediterranean-style diet rich in berries/veggies/fish, quality sleep, 7 to 9 hours, social engagement, and managing vascular risks, BP under 130/80, cholesterol control, can stabilize or improve mild concerns by 20 to 30%, reducing progression to dementia by up to 25 to 40% in at-risk groups. If symptoms are mild and not interfering with daily life, work, finances, driving, targeted imaging might not change management and could add more worry than benefit. Number 3. Cardiac stress test for vague symptoms like mild fatigue. Cardiac stress tests, treadmill exercise, nuclear imaging, or stress echo simulate exertion to detect significant coronary blockages. They're invaluable for clear symptoms like chest pain on exertion or shortness of breath. However, in seniors over 70 with nonspecific complaints, general tiredness, mild fatigue, walking uphill, guidelines from the American College of Cardiology/American Heart Association and USPSTF caution against routine use in asymptomatic or low pretest probability patients. False positive rates can exceed 40% in older adults due to age-related ECG changes or microvascular disease, leading to unnecessary invasive angiograms, with 1 to 2% complication risk, stents, or bypasses that don't always improve outcomes. Large studies in JAMA Cardiology and Circulation, including trials of over 10,000 patients, found that procedures following positive stress tests in low-symptom older adults often don't improve survival or quality of life, but increase risks. Bleeding, kidney injury from contrast, higher in those over 75, infection, or prolonged recovery. Safer alternatives for low-risk seniors. A simple resting EKG, coronary artery calcium, CAC, scoring via low-radiation CT, predicts events better in some cohorts. Blood tests for BNP or troponin if needed, or lifestyle optimization. Focus on modifiable risks, staying hydrated, balanced meals with adequate protein/iron, gentle activity, walking 30 minutes per day, and controlling hypertension/diabetes often resolve vague fatigue without testing risks, per observational data showing 50 to 70% improvement from lifestyle alone. Number 2. Routine colonoscopy for colorectal cancer screening. Colonoscopy remains the gold standard for detecting polyps and early cancer, with excellent outcomes when done appropriately. But per USPSTF guidelines, most recent comprehensive review 2021 reaffirmed in ongoing modeling through 2025, routine screening is recommended up to age 75, grade A. From 76 to 85, it's selective, grade C. Only for those in excellent health, no prior issues, and life expectancy over 10 years. After 85, it's generally not advised. Harms outweigh benefits. Why? Procedural risks rise sharply with age. Bowel prep can cause dehydration, electrolyte imbalances, kidney issues, or falls. Sedation risks heart rhythm problems or breathing suppression. Perforation/bleeding rates are 2 to 10 times higher, up to 1 to 2% in over 80s versus 0.1% younger, per large Medicare analyses of millions. One major study of over 1 million patients, published in Annals of Internal Medicine, found that in those over 75 without symptoms or family history, complications often outweighed prevented cancers, with net harm in frail individuals. Non-invasive options shine here. Annual/biennial FIT fecal immunochemical test, or multi-target stool DNA tests, like Cologuard, detect 90 to 95% of serious issues at home. No prep, no sedation, risks near zero, and comparable cancer prevention in modeling studies. If you've had multiple clean colonoscopies, e.g., 2 to 3 negative in prior decade, repeating after 75 to 80 adds minimal benefit, under 1% absolute risk reduction per extension. Always discuss alternatives. Shared decision tools from ACS or USPSTF can help weigh your personal risks. Number 1. Full-body CT scans for preventive or executive checkups. Offered by some private clinics as a comprehensive catch-everything early scan, whole-body CT uses high-dose radiation, equivalent to 300 to 500 chest X-rays, to image from head to toe in asymptomatic people. Major bodies like the American College of Radiology, ACR position statement, reaffirmed 2023 to 2025, FDA and USPSTF strongly advise against this for general screening. No proven evidence from RCTs or large cohorts that it saves lives or improves outcomes in healthy adults. Instead, it frequently detects incidentalomas, harmless nodules, cysts, adenomas, or calcifications extremely common with aging, in 50 to 80% of scans. These lead to diagnostic cascades. More scans, cumulative radiation raising cancer risk by 0.1 to 1%, biopsies, surgeries, infections, anxiety, all for findings with greater than 95% chance of never harming you, per ACR and radiology reviews. Long-term radiation modestly increases cancer risk itself. Targeted imaging only when symptoms, unexplained weight loss, persistent cough, or high risks, strong family history, warrant it. Otherwise, stick to proven prevention. Annual primary care visits with focused history/exam, symptom vigilance, vaccinations, and healthy habits. far more effective per population data. So, there you have it. 5 screenings where high-quality evidence shows less can be more after 70, promoting wiser, personalized care. Medicine advances rapidly, but guidelines remind us, one-size-fits-all often leads to harm in later life. Always ask your doctor, what are the absolute risks and benefits for me, not averages? What if something incidental is found? Are there safer alternatives? Tools like FREX for bones or decision aids for cancer screening can guide this. True longevity comes from lifestyle, daily movement, aim for 150-minute moderate activity/week, nutrient-dense eating Mediterranean pattern, strong social ties, stress management, mindfulness/meditation, and wise medical choices. These reduce overall mortality by 30 to 50% in studies like the Nurses' Health Study. What do you think? Have you had a conversation about de-intensifying screenings? Share your stories below. We love hearing from you. Thanks for watching BioVision. Subscribe, hit the bell for notifications, and we'll see you in the next video with more empowering health insights.